Hello, this is Gabriel, Associate Professor of Clinical Medicine at Methodist University. We will continue discussion of the concept of acid-base disorders. This is part 2 about the anion gap. In part 1, we covered the general concept of acid-base disorders and the compensation. In part 3, we will discuss the clinical applications of the concept of acid-base disorders, and we will see how we can reach to a diagnosis through flow charts. In part 1, we answered some questions. Suppose that we have a patient with acidosis. We need to tell is acidosis due to retention of CO2 or loss of bicarbonate. And we said that if there is retention of CO2, the direction of increase of CO2 is opposite to the direction of change in pH. This is respiratory. If it is metabolic, the direction of change of CO2 is in the same direction to the change in pH. For the second question, is there another problem with the primary problem? And the answer is, if the compensation as predicted, there is no other problem. If it is not as predicted, there may be another problem. Now we need to answer the third question. Is bicarbonate consumed by excess production of acid or loss in the kidney or GI tract? We have seen this slide in part 1, and we review it quickly. With production of energy from bicarbonate with excess oxygen or enough oxygen, enough insulin, there is production of volatile acid. CO2 would dissolve in water and result in carbonic acid, which can be get rid of at the lungs easily as CO2. But with the production of non-volatile acids or pathological acids like keto acids, or with the production of sulfuric acid, phosphoric acid, lactic acid, bicarbonate is consumed and there is production of an anion. It can be sulfate if the acid is sulfuric, can be phosphate, phosphoric acid, can be lactate, lactic acid, and so on. While if bicarbonate is lost in the kidney, there is no excess production of anions. So loss of bicarbonate, no excess production of anions. Consumption of bicarbonate by pathological acid will result in excess production of anions, sulfate, phosphate, lactate, and so on. And this is very important concept to differentiate between loss of bicarbonate and consumption of bicarbonate by pathological acid. Now we can answer this question. Is bicarbonate consumed by reaction with the acids or lost in the kidney or GI tract? If there is a lot of anions, there is consumption of bicarbonate. So increase in the anions means consumption of bicarbonate, and there are pathological acids. But how can we tell there is increase in the anions? Can we ask the lab to find for us if there is excess sulfate, excess phosphate, excess lactate, excess keto acid, and many others, maybe poisons, formic acid, formate, and so on? We cannot ask for all these tests. So how can we find that there's excess in the anions as a whole? This is the concept of the anion gap. All of you know about electrolysis. We can do electrolysis to any fluid. We put cathode, anode. The positively charged cations will be attracted to the cathode, and the negatively charged ions will be attracted to the anode. Suppose we get a sample of extracellular fluid and we did this test, electrolysis. What do you think? Will the cations be the same amount like the anions, or more or less? For sure will be the same amount, cations the same amount like anions. Otherwise there will be a charge on the body. Suppose that we were able to collect the cations in one tube and anions in another tube. The amount of the cations or positively charged ions is equal to the amount of anions or negatively charged ions. The main bulk of the cations is sodium, and the main bulk of the anions is bicarbonate and chloride. Suppose that we add sulfuric acid. It will react with the alkali bicarbonate. Bicarbonate will be consumed. The same amount of bicarbonate consumed by sulfuric acid will be replaced by sulfate. So line B will move down a little bit to give space, that is to say, to the new anions formed, and bicarbonate is less in amount. In other words, the anion gap will increase when we consume bicarbonate and replace it with another anion. But how can we measure the anion gap? As you see from this diagram, the anion gap is equal to sodium minus bicarbonate and chloride. Sometimes they include potassium in the calculation, but the most common it is sodium minus chloride and bicarbonate, or the area between line A and B. So any anion above line B on the right side is called unmeasured anions, and any cation in the left side above line A is called unmeasured cation. So the difference between unmeasured anions and unmeasured cations is exactly equal to the difference between sodium and between chloride and bicarbonate. And this is the concept of the anion gap. Now you see how when line B moves downward, bicarbonate is consumed, and the area for the anions on the right side or unmeasured anions will increase. That is to say, increase in the anion gap. And this is what we call anion gap acidosis, and the main cause is production of pathological acids, or the kidney cannot get rid of the anions, as in renal failure. It is clear from this diagram that the increase in anion gap, which is colored red, equals the decrease in bicarbonate, which is colored yellow. But in fact, not all the acid that is added is buffered by bicarbonate. It is also buffered by intracellular buffers. So we consume actually less bicarbonate. Now, what happens if we lose bicarbonate in the kidney or GI tract? Line C will move up, chloride increase, and line C will move up. The anion gap will not be affected. And this is known as non-anion gap acidosis or hyperchloremic acidosis. This slide shows us the normal gap acidosis. If bicarbonate is lost, the chloride will increase in amount and takes the room of the lost bicarbonate, the yellow area. So line C will move up. And this is what we call hyperchloremic acidosis. The anion gap is not affected. There is normal anion gap. What about if the patient has less albumin? You note that albumin is calculated or is present in the area of unmeasured anions. So his normal anion gap without any changes in acid-base balance is less than 12. 12 is the normal, but the patient has less albumin. His normal anion gap is less than 12, maybe 8. So if you measure the anion gap and you find it, for example, 12, you can say it is normal. His normal should be less than this. And in order to not confuse and misdiagnose patients with hypoalbuminemia, we have to correct the anion gap for patients with hypoalbuminemia by adding 2.5 the deficit in albumin. Normal of the albumin is 4, so 2.5 the deficit of the albumin from the normal 4. So, what are the causes of increase in anion gap? As we saw in the diagram, there is increase in production of acids, non-volatile acids that will react with bicarbonate and leave behind the anions. If we don't have enough oxygen to burn glucose for any reason, lactic acidosis will result. In order to get oxygen, there must be good lung, good heart circulatory system, and the mitochondria are working properly. If there is defect in oxygenation of hemoglobin at the lung, or defect in circulatory system in the whole body, like in case of shock, no enough perfusion of tissues, or in a localized part in the body, as in ischemia of a limb or part of the intestine, in all these conditions, lactic acid is produced, and lactate will cause increase in the anion gap. In normal conditions, the body uses glucose or burn glucose with using insulin and oxygen to produce energy. What about if there is no enough insulin? Keto acids are produced. What about if there is no enough glucose, like in starvation? The body is going to use the fat stores. What about if the body uses ethanol to produce energy? All these conditions will result in ketoacidosis and increase in the anion gap due to production of pathological acids. Also, anion gap increases in cases of poisoning with methanol, ethylene glycol ingestion, or toluene inhalation. If production of energy is okay, but the kidney cannot get rid of the anions due to renal failure, in this case, the anion gap will increase also. What are the causes of changes in anion gap not related to production of pathological acids or kidney disease? Now, what are the causes of increase in anion gap? Increase in the unmeasured anions will cause line B to go down and the anion gap will increase, or decrease in unmeasured cations and line A will go up and cause increase in anion gap. So high anion gap can result from increase in phosphate, increase in albumin, and in case of alkalosis, the negative charges of albumin will increase, and this will cause high anion gap. Now, what are the causes of decrease in anion gap? The opposite. Line B moves up, as in hypoalbuminemia, or decrease of the anions like phosphate, or line A goes down due to increase in cations like potassium, calcium, magnesium. So low anion gap in case of hypoalbuminemia or increase in positive charged proteins, as in monoclonal immunoglobulin G in multiple myeloma. And in fact, if we find low anion gap, very low anion gap, we have to think in multiple myeloma. Increase positive ions as potassium and calcium. Some lab machines interpret bromide as chloride, and this will result in low anion gap. This is seen in mistinone for treatment of myasthenia gravis. It contains bromide, and this will cause line B to move up. We mentioned before that the cause of the anion gap is consumption of bicarbonate with acids and production of an anion which will add to the unmeasured anions, and that the amount of bicarbonate consumed is more or less equal to the amount of anions produced. So if we relate the change in anion gap to the change of bicarbonate, it equals 1, more or less 1. And this is what we call delta ratio. Increase in the anion gap divided by decrease in bicarbonate. So delta gap equals change in anions or increase in anions divided by change in bicarbonate or decrease in bicarbonate. Normally it is slightly greater than 1 because some acids are buffered inside the cell and their anions will add to the anion gap without consumption of bicarbonate in the extracellular fluid. What is the benefit of calculation of delta ratio in acid-base disorders? Number 1, there is a certain pattern of delta ratio during an elevated gap metabolic acidosis. This pattern depends upon the etiology of the elevated gap. Number 2, we can use delta ratio in diagnosis of presence of another metabolic disorder, as we are going to see in the next 2 slides. In this slide, we see the effect of pathological acid production on delta ratio. If lactate is produced, as in lactate acidosis, the ratio will increase gradually from 1 up to 2 as the severity of lactic acidosis increases. Number 2, in ketoacidosis, delta ratio increases to maximum of 1.2. So we don't like to diagnose ketoacidosis if the ratio is more than 1.2. Suppose that the anion gap increased by the amount E and bicarbonate decreased by the amount D. In this case, the delta ratio will be E divided by D, which equals here 1. Now, suppose there's another process of alkalosis adding bicarbonate. In other words, the area D is getting smaller. In this case, because the denominator is smaller, the ratio E over D will be more than 1. So, in cases of metabolic alkalosis, delta ratio is high, usually more than 2. This is a graphic representation, and you see here the increase in bicarbonate from a process of metabolic alkalosis will shrinken the area D, so E over D is increasing. Now, suppose there is loss of bicarbonate from another process of non-anion gap acidosis. So the area D will expand as the area of the bicarbonate shrinks. In this case, the ratio E over D will decrease. So, to summarize, what is the diagnostic value or importance of delta ratio? We calculate delta ratio if only there is elevated gap acidosis. If the ratio is lower than expected, this means additional normal gap metabolic acidosis. If it is higher than expected, this means additional metabolic alkalosis. If it is within the range, this means only elevated gap acidosis, and we look at the pattern of change of the delta ratio. If it is increasing slowly from 1 to 2, we expect lactic acidosis. If it increases to a maximum of 1.2, this is ketoacidosis, and that's it. As an alternative to the delta ratio, we can calculate the delta gap. There is an easy way to interpret or diagnose a secondary acid-base disorder. We add to the delta gap the bicarbonate of the patient. It should be between 18 and 30. If it is more than 30, this means there is another process of alkalosis. If it is less than 18, this means there is another process of non-anion gap acidosis. We are going to practice many examples to demonstrate how we use delta ratio and delta gap. How to interpret mixed acid-base disorders with normal pH. Can we have a normal pH while there is acidosis or alkalosis going on? Yes. There may be process of acidosis that cancels the process of alkalosis. As you see here, pH is proportional to fraction bicarbonate divided by CO2. Increase of both bicarbonate and CO2 will keep the fraction as is without change. Also, decrease of both bicarbonate and CO2 will keep the fraction unchanged, provided the increase is the same or the decrease is the same. Important point here, if we see pH is normal, do not calculate or look for compensation. We can make diagnosis from anion gap, or we can look at the following table and conclude the diagnosis. Now, if we have a patient with normal pH, and again this table applies for normal pH. If the pH is normal and both CO2 and bicarbonate increase, this means respiratory acidosis or metabolic alkalosis. You don't need to memorize the table. You know the principles. A change in CO2 means respiratory, change in bicarbonate means metabolic, increase in CO2 means respiratory acidosis, decrease in CO2 means respiratory alkalosis, increase in bicarb means metabolic alkalosis, decrease in bicarb means metabolic acidosis. And also you know, increase in anion gap means anion gap metabolic acidosis. Applying these rules, we can conclude this table. But we have to pay special attention to the second row. We have high anion gap means anion gap acidosis, which effect is cancelled by low CO2, which means respiratory alkalosis. Bicarbonate now should be normal. If it is low, there is another metabolic disorder, and this depends on the case. Also pay attention to row number 3. To start with, there is high anion gap means anion gap acidosis. We need something to cancel the effect of this acidosis, but CO2 is normal and the bicarbonate is normal, so there must be a hidden metabolic alkalosis that cancelled the effect of anion gap acidosis. Now we have discussed anion gap, and we understand that abnormal acid production will increase the anions and increase the anion gap and consume bicarbonates. What about if bicarbonate is not neutralized by the acid, just lost in the kidney? This will result in normal anion gap acidosis. Also, normal anion gap acidosis can result from loss of GIT secretions in any form from duodenum to the end, like in diarrhea, urethral diversion, colostomy. The kidney can cause acidosis by two mechanisms. loss of bicarbonate, as in type 2 renal tubular acidosis, or inability to excrete hydrogen, as in the kidney can affect the acid-base disorders by two mechanisms: loss of bicarbonate, as in type 2 renal tubular acidosis, or inability to excrete hydrogen, as in type 1 and type 4 renal tubular acidosis, or renal failure or hyperkalemia. Also, acidosis, non-anion Gap acidosis, can happen in case of infusion of normal saline or ammonium chloride. To understand the effect of the kidney or the role of the kidney on acid-base disorders, we have to understand how the kidney regulates the different anions and cations and the role of each part of the renal tubules. Imagine that you want to clean out your closet. You get out everything and you put back what you need. Same thing in the kidney. Everything is filtered. Tubules will pick back what the body needs. To make it very simple, we have to memorize that at the proximal tubule we get back sodium, and sodium is positive. We have to get negative ions with it, either bicarbonate or chloride, according to the needs of the body. In the distal renal tubule, sodium also is reabsorbed, and to keep neutrality, sodium is absorbed as a positive ion. We have to get rid of a positive ion. So sodium is absorbed in exchange of potassium or hydrogen according to the needs of the body. Again, this is very important. Proximal tubule, we absorb sodium and chloride or bicarbonate. In the distal tubule, we absorb sodium, and in exchange of sodium, we excrete either potassium or hydrogen. And this effect or action of absorption of sodium in exchange of hydrogen or potassium is under the effect of aldosterone. And if the body has excess hydrogen ions, as in case of acidosis, we're going to excrete hydrogen in exchange of sodium. But if the body has excess potassium ions, we would like to increase the percentage of potassium excreted in exchange of sodium. If you fill a cup of tea to 2/3 with tea, then you are left with 1/3 to be filled with milk. If you fill it to 1/4 with tea, you are left with 3/4 to be filled with milk. you can imagine and memorize the relations of bicarbonate to chloride and blood volume, and the relation of hydrogen to potassium using the same concept. Bicarbonate and chloride in 1 cup, bicarbonate and volume in 1 cup, hydrogen and potassium in 1 cup. For the first cup, we can memorize the relation between chloride and alkalosis or acidosis. If we increase chloride, bicarbonate will be less. So we have a condition of hyperchloremic acidosis. If we decrease chloride, bicarbonate will be more. So we have a condition of hypochloremic alkalosis. And there is a general concept that the volume is related to sodium chloride together, or to sodium content only, or chloride content only. So same relation between bicarbonate and chloride applies for the relation between bicarbonate and volume. So we can have contraction alkalosis when bicarbonate increase and the volume decrease. If we infuse saline, there is infusion acidosis. For the third cup, we mentioned that we retrieve sodium in exchange of hydrogen or potassium. For the third cup, hydrogen and potassium are in reciprocal relation. So increase in hydrogen means decrease in potassium. Decrease in potassium means increase in hydrogen, and vice versa. So we can get hyperkalemic alkalosis, that is to say, loss of hydrogen ions with increase of potassium, or hypokalemic acidosis, that is to say, loss of potassium and increase of hydrogen. Please remember these relations. They are a little bit confusing, and this is the easiest way to remember them. What type of metabolic acidosis occurs in renal failure? If the renal tubules are failing only, there is loss of either bicarbonate, or there is inability to excrete hydrogen, and this will result in renal tubular acidosis and has nothing to do with the anion gap. But when creatinine clearance is less than 40 milliliters per minute, the kidney will start failing excretion of anions. So anions will build up, and this will cause anion gap acidosis. Now let us start practicing some cases. Please pause the video and find out what acid-base disorder is present in this patient. We check pH 7.46, that's above the upper limit, 7.44. By definition, there is alkalemia, And if there is alkalemia, there must be at least one process of alkalosis responsible for this alkalemia. Is it respiratory or metabolic? Look at the direction of change of pH and PaCO2. pH increased, PaCO2 decreased. So this is respiratory alkalosis, the change in different directions. We can conclude from the history that the patient has acute respiratory alkalosis. Now we evaluate compensation. From the table that we have, the compensation for acute respiratory alkalosis is 2 to 10. And again, remember, because CO2 decreased, we need to decrease the bicarbonates. Since it is acute respiratory alkalosis, from the previous table, for every 10 units decrease in CO2, there is 2 units decrease in bicarbonate. 16 multiplied by 2/10 equals 3.2. And again, this is change. So we add this 3.2. The normal is 24 minus 3.2. So the predicted bicarbonate should be 20.8. Since bicarbonate is 18 at the patient case, there is another process of metabolic acidosis. And if there is metabolic acidosis, we always calculate anion gap. The anion gap is 23, elevated anion gap. If the anion gap is elevated, we calculate delta ratio, which is change in anion gap divided by change in bicarbonate. And this change from the normal. It equals 11 divided by 6. 11 is 23 minus 12. The patient anion gap minus the normal anion gap divided by 6, which is the normal bicarbonate 24 minus 18. So it equals 1.8. And we learned that the diabetic ketoacidosis, the anion gap ratio is less than 1.2. So the case is most probably due to lactic acidosis. So we have respiratory alkalosis and lactic acidosis. Case 2. Please pause the video and try to answer. Check pH. There is acidemia and at least one process of acidosis. Is it respiratory or metabolic? It is metabolic acidosis. Now we evaluate the compensation by applying Winter's formula. PaCO2 should be 18.5. So there is respiratory acidosis. But how come there is respiratory acidosis and PaCO2 of the patient is 20? The patient is trying to compensate, but he could not reach to the predicted level of 18.5. Only his PaCO2 is 20. There must be a process of respiratory acidosis that prevented the patient from reaching the predicted compensation. Because there is metabolic acidosis, as always, we calculate anion gap. It equals 30. It is elevated. And when anion gap is elevated, we calculate delta ratio. It equals approximately 1. We have no diagnostic value for delta ratio 1. Any cause of elevated anion gap metabolic acidosis can result in delta ratio around 1. So the final diagnosis of the acid-base disorders in this patient is anion gap metabolic acidosis with respiratory acidosis. And that is the end of part 2. In part 3, we'll go to clinical vignettes and discuss differential diagnosis. I hope I was able to make it simple and easy and clear. And this is the way I like to study medicine. Make it very clear and very simple and one story. I have a PowerPoint presentation about how do I study medicine and how do I teach medicine. It is available on the link in the description of this PowerPoint presentation.